Awesome. Great. Thank you. We're excited to be here today for this forum to share with you our fruit and veggie prescription program. We hope you enjoy our presentation on producing powerful partnership to optimize patient outcomes. And with that, I will turn it over to Paul, our partner from the RCHN Community Health Foundation.
Welcome, everybody. My name is Paul Melinkovich. I have worked as the clinical consultant from the RCHN Community Health Foundation and had the great pleasure of working with these individuals that you're going to be hearing from later, these great women, about with a project on food and vegetable prescriptions for patients with diabetes. The RCHN Community Health Foundation was founded in 2005, and it has a mission of supporting the nation's community health centers through research, advocacy, and targeted funding initiatives. In 2015, they developed a population health initiative and funded 7 projects in 2015 and an additional 7 in 2017. In all, we funded 10 community health centers and 4 PCAs with the goal of increasing capacities in the community health center to address population health and at the same time to address the social determinants of health that lead to health disparities. Next slide. In 2017, RCHN funded the Idaho Primary Care Association to develop a fresh fruit and vegetable prescription pilot project at 2 community health centers. You're going to be hearing from those community health centers about the work that they did. This prescription pilot was for patients with poorly controlled diabetes, and the goal was to develop the program such that it could be spread from these 2 health centers to other community health centers in the state of Idaho. It goes without saying, I think, that this kind of work is important. I suspect all of you understand why it's important, but just to mention the issue here of great importance is food insecurity is a major issue for community health center patients. I think all of you experience that with the patients that you take care of. It is particularly an issue for patients with diabetes. And this FVRx program gives healthcare providers an additional medicine, fresh fruits and vegetables, for treating patients with diabetes. Sarah, it's yours.
Awesome. Thank you, Paul. So further on in our presentation, we would like to have some discussion with you all. These are the 2 questions that we will be providing to facilitate that discussion. We wanted to share them to you now so that you can think them over and kind of plan out what your response is going to be. We would like to use the interactive platform of Menti as a visual, so please be prepared to go to that address. Menti will display your responses as a word doodle, so words or small phrases will work best when it's that time. We posted the questions as well as the link in the chat. I'll go ahead and post it again since other things have been posted in there to make sure that you can find it, and then I'll prompt you when we get to that part in the presentation as to when you can initiate your questions. So we at the Idaho Primary Care Association wanted to support a project working with our federally qualified health centers to help improve the outcomes for patients with diabetes, as well as support their efforts to address food insecurities. The generous support from the RCHN Foundation helped to make this happen. Our project plan and the role as Idaho's Primary Care Association was to collaborate with our health centers on a food as medicine prescription program. We wanted to target patients with diabetes. We also incorporated those with hypertension and those who had an elevated BMI in the first year. We wanted to obtain information regarding food insecurity for the patients that we're serving And so we wanted to make sure that there was a pre and post survey or information provided. Then as the grant recipients, we monitored the reporting as well as ensured the project objectives were met as we went throughout the program. And then we also wanted to make sure that we incorporated social determinants of health capture into this work, as it is a focus area for health centers. So that was included in the project. We also then wanted to incorporate formal evaluation into the project at the end so that we could capture the lessons learned from the work that was done. This right here is, so we worked with 2 FQHCs, and you'll hear from the 2 FQHC dietitians that we worked with in this presentation, but we wanted to provide just a quick overview of the project, showing the similarities and differences between the program at the FQHC level. Now I'm going to turn it over to Ray, who was our first FQHC dietitian partner that we worked with. She's from Reilly Health Services.
Thanks, Sarah. My name is Ray Krick. I'm a registered dietitian at Reilly Health Services up here in Boise, Idaho, Nampa, Idaho. I know we have participants from kind of all over the place around here. So I've been at Reilly for the last 3 years. We're a federally qualified health center, like Sarah said, serving about 40,000 patients here in the Treasure Valley for the last 50 years. And we kind of see a range of patients all across the board that are just seeking some quality, affordable healthcare, as many of your clinics do as well. When I started here at Reilly, I actually came on to this grant that RCHN provided our clinic through the IPCA, and it really helped to establish my role. So it's been great. I've been here since 2018, and this was really the first 2 years of my work here. So I'm excited to talk a little bit more about it. Go ahead, Sarah, and move to the next slide. Okay, so RCHN provided us this grant. Like I said, I didn't get to be a part of writing the grant, but I was stoked to come on as Reilly's first dietitian, and that was one of the goals of this grant for sure. But as Paul was saying before, kind of the goal was to provide some fresh produce, fresh foods to address chronic disease, particularly diabetes, as well as our patients' food insecurity. So we received this grant for 2 years. The first year, like I said, brought on a dietitian, which was me, and then supported this produce program as well. And then we rolled into year 2 with a second clinic, and Lindsay will talk to you guys here just in a little bit about her experience at the second clinic. So we received funding from RCHN, and from then it was up to us to kind of decide where we were going to get this produce, how we were going to distribute it, who we were going to give it to, and then, how to contact these patients, what we were going to track, and then on what kind of timeline. So they provided us the tools, and then we just had kind of the program to set forth. And it was a really cool project for me to take part in. And one piece that I initially just thought would be really important, just off the patient care that I had already provided, was the education to go along with this produce. Between Boise and Nampa, we do have kind of a mixture. I think just over 50% of our patients in the Nampa-Caldwell region are Hispanic, and then more over in Boise and Meridian, a little less of a percentage. So the produce among both cultures is a little bit different, and a lot of our patients didn't know kind of what to do with this produce. So we included some education also, and I'll talk a little bit about that as well. Go ahead to the next slide, Sarah. Okay, so like I said, I got to take part in this for 2 years, and I'll talk a little bit about year 1 first, and then the comparisons between the two, and then we'll kind of compare to Lindsay's program here shortly. So as I said here, sorry, Sarah. Okay. Year 1, the grant funded bringing on a dietitian onto the team, as well as the produce program. We enrolled about 174 families, and I'll talk a little bit about enrollment and a few of the steps here. So the first year we used our diabetes registry to contact patients. So we have about 10% of our population or 4,000 patients with diabetes. And we kind of went through our diabetes registry according to those points that Sarah briefly mentioned. So an A1C greater than 9 and a BMI greater than 30. So we went through and kind of dwindled down that list and just started making phone calls to see who we wanted or who wanted to participate with us. So that was our enrollment process. And those two numbers were what we were watching for in year one. In the first year, as you can see in these photos down below, we brought the produce to us. So during the summer, we partnered with the Boise Farmers Market, and they brought their produce van out and set up a beautiful little produce market in one of our conference rooms, and patients attended our market once a week on Wednesdays. So they received their produce weekly, and we didn't have control over what produce was brought in, but we did get to see what they were taking home, which was fun. And then the education that we provided the first year was one-on-one visits with myself, some medical nutrition therapy, which many dietitians, of course, are familiar with. We also provided curriculum-based group classes called Healthy Diabetes Plate. Those are local to Idaho. And then the Cooking Matters courses through Share Our Strengths, and we partnered with the Idaho Food Bank on those. So they had 3 options of education that they could attend, but they had to attend the education to come to the market. So we really paired those together and used the food as an incentive to receive that education. So that was more so year one. I'll talk a little bit about the differences. So rolling into year 2, not only did we expand to another clinic, which was amazing to be able to do, thankful to RCHN for that. We enrolled patients a little bit differently in year 2 after learning from year 1. So by this time, our providers had kind of cued into this program and its success, and our patients were raving about it. So we started enrolling patients via referrals. So our providers were in on it. Of course, when I saw patients in visits that qualified, I enrolled them myself. And we also limited or lessened the qualifications. So the second year, we only required an A1C greater than 8%. No BMI, just because the focus of this program wasn't so much weight loss as it was addressing diabetes and their food insecurity. And as many healthcare providers know, an A1C of 8 is not only well controlled, but sometimes we see some big sways in their blood sugars. So they may still have blood sugars in the 300s at times. So it was important to address a wider scope of people. As you can see again on the slide up above, there was no market. We did not host a market in year 2. This is exactly what our vouchers looked like. So we actually partnered with a handful of local small family-owned grocery stores to provide our patients produce. And these are the vouchers that we gave once per month. So I'll talk a little bit about the dollar amounts in just a minute, but we gave them 1 month of vouchers at a time, and then they could attend any of these grocery stores at a time that made more sense for them and their family, as opposed to having to make Wednesday afternoons from 3 to 5 work every week in order to get their produce. So the second year, we provided similar education. We did one-on-one visits again. We did not do the group classes. We did do the cooking classes still. The third option they had was education with our clinical pharmacist. I'm on the pharmacy team here at Terry Reilly. So that was a great partnership. And of course, our patients with diabetes are on diabetes medication as well. So they were still receiving some education that way. Go ahead and go to the next one, Sarah. Okay, so this is a very busy slide, and for that I apologize, but I do want to make just a few notes on here, and I'm not sure if you'll have access to these later, but if you have any questions, of course, get a hold of Lindsay or Sarah or I. So this was our flow for year 2, and the things that I kind of want to make note of again, one is that we enrolled patients according to a lower A1C. So A1C of 8 was the only qualifier, and that made it a lot easier to enroll as many patients as we wanted to and to really help the most people. I forgot to mention that in year one, we kind of did 3 large cohorts of sorts. We enrolled like 50 to 60 in waves. We still kind of did the program year round, but the second year, we really did like an ongoing basis. So patients were enrolled for a few months at a time, but I could enroll people on Monday, April 1st, and then, Wednesday, May 16th. There was no real solid dates that they had to be enrolled by. I also mentioned the dollar amounts, if that's important or you're wondering how much we were giving. The original RCHN grant did say, I think it was $1 a person per day. We kind of simplified that a little bit just to make math a little easier on us. So as you can see, it was about $10 a week per person. In year 2, they did get a month of vouchers at a time. They were still required to attend education to get their vouchers. Cooking Matters was our most popular choice. They loved the cooking classes. And then just making mention, there's our partners right there. Of course, if you're not from Idaho or the Treasure Valley, you may not recognize those. But we did have 5 small family-owned stores that we partnered with, which was fun to get to support the community in that way also. Go ahead to the next one, Sarah. Okay, so again, this was my first 2 years out of college and also at Terry Reilly for me. So we had really incredible results, not only through RCHN and for the clinic itself, but this was just an amazing experience for me. So for RCHN, great to get to talk to Paul and Chad over the years, but we really did have a successful program. We'll go through some of our results with Barbara later. Terry Reilly, we established a dietitian role, which, as many of you know, is a huge win. Especially for the population we serve. And it really brought to light that food security is a huge issue among our patient population. So that was ideal to kind of bring to light as well. We did some community outreach through this program. It's been made well aware among many of our community partners. It also allowed us to apply for additional grants and continue the Cooking Matters program. And then for me personally, this really just launched my career. I've made connections and friendships with these people that I wouldn't have been able to make otherwise. And it's really given me an opportunity to practice speaking and presenting. Like today, I've presented far more than I ever thought I would. But it's been really fun to present on something that I really got to take such part in. And I think that's probably all that I have for my slides. Please make note of any questions that you might have. And then I'm going to pass it over to Lindsay, who took part right next to me in the year 2. It was really great to partner with another dietitian. So go ahead, Lindsay.
Thank you, Ray. So my name is Lindsay Grosvenor, and I'm also a registered dietitian and am working for Valley Family Healthcare, which is a health center that provides services in both Idaho and Oregon. We're really kind of right on the border there in the western Treasure Valley. And I've been a dietitian for nearly 20 years. My first 15 or more were actually working in public health, so primarily for the WIC program, if you're all familiar with that. So that's kind of my background. And I had been with Valley Family for just over a year when IPCA reached out to us and asked if we would be interested in partnering with them for this program. So between our 8 medical clinics and 3 dental clinics, we provide care for approximately 20,000 people in our rural community each year. And at least 35%, a little over that, between 35 and 40% of our residents identify as Latino or Hispanic. Next slide, please, Sarah. So, like I said, we were fortunate, Valley Family was fortunate to be chosen for the year 2 expansion of this produce prescription program that started at Terry Reilly. And while both of our programs, our models looked they looked similar, there obviously were some differences. Our target population was actually, of course, very, very similar, and our eligibility criteria we made sure was the same. So we did use that same 8% A1C or higher as a criteria. We also, between our 2 clinics, really worked, especially in the second half of our program, to standardize our evaluation methods using validated tools and making sure that we were really evaluating the same thing. So in addition to myself, we had a dedicated staff person, kind of a project manager, which was really helpful for that first year getting started. And she also happened to be a behavioral health consultant. And so she played a big role in helping with this project. We also have several, I think 5 or 6 community health workers at Valley Family Healthcare, and they were integral in helping to screen and refer patients to the program, as well as connecting them to resources for other social influencers of health that they identified. They also provided a lot of support and interpretation for our group classes. Next slide, Sarah. Thank you. So our goal overall was to provide the produce, the vouchers to at least 60 households, patients or households. We did end up in accomplishing that and enrolling them. We did have a few drop out for various reasons. Mostly, one of them I think moved out of the state. Another happened to was a truck driver and had difficulty meeting some of the education requirements. And then we had one drop out because a lot of our vendors, the stores that were participating, were too far away from where she happened to live. So we chose to roll our program out into 2 separate 4-month cohorts. For both cohorts, participants were required to choose one educational component, and that could be, like Ray provided, the Healthy Diabetes Plate group class, Cooking Matters, a group medical visit, or an individual counseling appointment with myself or one of our behavioral health counselors. With that, in cohort 1, we did issue vouchers weekly, similar to what Ray was doing, to incentivize that group class attendance. Group medical visits included a guest speaker to present on different topics, such as nutrition, which was myself, medication management, stress management, and physical activity. And their assigned provider was on site to actually go over some of the medication updates. And they did have an additional BHC, behavioral health counselor, to support any kind of health goals. So I know Ray mentioned Cooking Matters. If you're not familiar with it, we had so many of our participants chose Cooking Matters as their preferred educational component with this. And I think a lot of it had to do with the fact that when you participate in the live group classes, they're hands-on, but they also receive groceries to take home with them to make the recipes that they learn in this class. And so we found that the majority that enrolled happened to be those that also self-reported food insecurity. So it was one of our most popular options, and was really well received for sure. So prior to cohort 2, we happened to lose our behavioral health counselor and provider team that was based out of our Payette clinic. And so we ended up in cohort 2 changing things slightly. Again, kind of similar to what Ray did at Terry Reilly. We moved our target, patients to our Oregon side, Ontario clinics, because that's where the majority of our vendors, our local stores, as well as farmers markets, were located. So that kind of eliminated some of the transportation barriers. And then we also chose to do a monthly group visit, similar to the medical visit, that had that same education component, but that's when they would receive their vouchers, was monthly instead of weekly. If you saw the vouchers before, we were having to handwrite in the expiration dates, the participant IDs on each individual voucher, and that just really became cumbersome. And so we made some modifications to our voucher, and then we also were distributing these monthly instead of weekly, which really helped to reduce staff time, just for some of those administrative things. So we also, again, in cohort 2, chose to eliminate the Healthy Diabetes group class, just because this was determined was not an evidence-based program, and we wanted to make sure that we were using evidence-based interventions as much as possible. So sadly, since we were we were towards the end of the year, when COVID-19 hit, we were halfway through our second group of Cooking Matters classes. And so we had to stop those midway through. And then for the remainder of our 2 months worth of benefits for this group, we made phone calls, we did video calls, some telehealth visits, and then we mailed them some education, the same kind of educational topics that we initially planned to do, along with their vouchers to their home address on file, or if they chose to pick them up at the clinic, they could do that. So that was, the other thing that we did, I was going to say, we chose to do, rather than individual kind of orientation or enrollment visits, we did those kind of a mass orientation at one time. So kind of enrolled everyone at the same time. And then we did a graduation at the same time as well. And to incentivize the completion of the graduation and the post survey, we did provide them with a small denomination of a Walmart gift card, as well as a name and their name and a drawing for cooking equipment, which did help us to collect that information. Go ahead and go to the next slide, Sarah. So this is similar to Ray's busy slide. This was really just a process map to help with staff who were involved in helping patients enroll. So they kind of knew, okay, so this is their criteria, this is the number of people, this is what they have to do, this is the requirements for participating. And we did, again, kind of that first year, we worked off of a patient registry for those that met the criteria. And, come second cohort, we really had, I had referred a lot of individuals or patients that I had already been working with and doing some individual counseling with, and we did have providers do internal referrals. So it was kind of a clinic-wide between myself, community health workers, and providers, how they basically got into the program. So as Ray mentioned, the dollar amount there really was, so some families were receiving up to $200 a month just for fresh produce. So this was just fresh fruits and vegetables, which compared to other programs, at least in the state of Idaho and Oregon that are currently operating, and most of them are receiving a maximum of $60 per household, kind of regardless of the size. So this dollar amount, this monthly benefit amount, was definitely higher than you will often see. But I guess one thing to note, and Barbara will speak to this more, but the redemption rate, at least for our clinic, was around 65% or so. I think almost everyone spent some, but 65%, I believe, was the average redemption. And it really didn't seem to make a difference anyway how much they spent as to that connection in the health indicators change or change in the reported food security. So that's just a really interesting factor there. Next slide, Sarah. So like Ray mentioned, there were many value-added benefits that resulted as part of this, us participating in the produce prescription program. Within the clinic, I already mentioned, the patients really loved the group aspects of Cooking Matters or any of the group classes. To be honest, I had a couple participants that actually chose to do all three because we did them in different order. So I had one that did the healthy diabetes group plate class. She also did Cooking Matters. She also did the group medical visits. She really wanted to just soak it all in. And so that was a really cool part of that. And I really truly believe that besides the education that they receive around food budgeting and, the self-efficacy around food preparation is really just the social interaction. I feel like especially our older patients are really isolated, especially now. And so finding ways for them to engage with each other is really important. So the other thing that kind of happened as a natural consequence of this was that referrals to myself and for nutrition counseling did increase because providers knew about this program, and they also really trusted me to provide, education and nutrition counseling for other chronic health conditions. And then, of course, just the working as that care team, providing wraparound services to really our most vulnerable patients using, our BHCs and our behavioral health counselors, our community health workers and providers, really to build those relationships, even internally, were definitely a benefit. And then one unique kind of collaboration that happened, I believe, as a result of this, because we were working already closely with our Idaho and Oregon food banks because of Cooking Matters, is that when COVID hit and our food pantries were temporarily kind of shut down because the volunteers that were running them happened to be our older population who were, wanting to stay home, and they were worried about being exposed, we had really limited access to emergency food in our area. And so we collaborated with the food bank in Oregon, and as well as just our social service provider agencies in our area, to provide and hold 3 mass food distribution events where we had over 200 households come and receive emergency food in our community. And that was a really, really cool collaboration. And then since then, we've also obtained some additional funding for Oregon Medicaid participants, plan members, to continue funding for a produce prescription program based in our Oregon clinics, and again targeting our, of course, lower income, but also those that have diabetes or a nutrition-related health condition. And then one thing I definitely like to point out, and this is really great, especially for states that are providing alternative payment reimbursement other than, just for the actual billable medical nutrition therapy for dietitians, is and Oregon does provide this. So if you provide group classes or you do health and wellness calls, there's reimbursement, on the front end for programs like that. And I believe that between that and our community care organizations, those are the programs that are going to help ensure that prescriptions like this are sustainable. Instead of us having to go out and find grant funding all of the time to make this happen. Besides the fact we should want to provide these services because overall it helps to improve the health of our patients, right? And overall reduced cost. So I think that's all I had. Up next is Barbara Gordon, and I'm going to let her introduce herself, but she did our evaluation along with Andrea Jeffrey, and take it away, Barbara.
Hi, so I'm Barbara Gordon. I've been a dietitian for decades, and I'm currently an assistant professor at Idaho State University in the Department of Nutrition and Dietetics. And I was really honored to be approached by Sarah to ask to be involved in this team and do an independent evaluation to see whether or not they were able to really make a difference in the lives of these patients. I do want to just acknowledge my graduate assistant, Andrea Jeffrey, who helped me with this evaluation. So next slide, please. I'm going to use my time in 2 ways. I'm going to give you statistics in terms of how well we did, but I'm also going to guide you through some of the types of information to include in that evaluation section of a grant application. So I was thinking, I don't want to totally geek out on you guys. So I want to give you some tools to take away as well. So one of the things in terms of evaluation is there's actually 2 different types of evaluation you generally do for a public health program. One, you want to look at the process. So when you apply for a grant or you put together your program plan, you say, this is what I'm going to do, and this is how I'm going to do it. So an evaluator looks at, did you do what you said you were going to do? And did you do it how you said you were going to do? But an evaluator also looks at barriers. What barriers emerged, because they always do in public health programming? And then how did you overcome those barriers? What were your workarounds? And then in terms of outcome, that's where we really want to say, was this program effective? So for the folks who participated in this program, did it result in favorable changes in A1C? So did it provide better diabetes control? And also, did we see any reductions in body mass index? There wasn't a goal to reduce weight, but there was a goal to improve overall health, which could relate to reducing that body mass index. And as you're probably aware, bringing down weight for folks who are overweight or obese can also help to increase their diabetes control. So those were some of the outcomes that we looked at. Next slide. So this is a template for a logic model. A lot of the grants do require you to submit a logic model when you put your application in. And so I pulled a template that you can use if you're required. I put one together as an evaluator. This is often the first thing I do because it helps me to get the big picture of what's going on with the programs. And the one I put together did not project well, so I pulled it out. But if you want a copy, email Sarah and she'll give you a copy of it. I'm just going to highlight a couple of things that when you're thinking about a logic model, it's a great task to make yourself do when you're putting your grant application together as well, because it just makes you think through that whole process. So often, we kind of think, okay, what are the inputs? So, we need to have the staff, we need to have the resources, but for the fruit and vegetable programs, a really important part of that input were the partnerships. So the partnerships with the food bank for the Cooking Matter classes, the partnership for the grocery stores and the vendors in order to get access to the produce. So starting to think about that level of detail early on is really important. So if you have additional questions about logic models, Sarah can hook you up with me. I'm happy to respond to questions about them. But I would say it's a great way to just make yourself think through on a detailed level what's going on with your program. Next slide. So an evaluator also looks at what you propose to do. So when I looked at these two programs, they had certain strategic interventions. They said they were going to propose to achieve their goal. And their goal was really promoting that behavioral change, that increase in produce that hopefully would reduce A1C. So one of the things I did was I went to the scientific literature and I looked at the different strategies and I said, has someone else implemented this strategy? And if so, did they find that it was effective? And indeed, for the strategies for this program, I was able to find evidence in the literature supporting each of those strategies. So the dietary education provided by a dietitian, the Cooking Matters classes, distribution of fruit and vegetables via community partners, individual appointments with pharmacists, and group visits with behavioral health. These are all strategic actions that have been used around the country for these types of populations to promote behavioral change, and people have reported that they have been successful. So I was glad to find out that the strategies they were engaging with did have evidence supporting them. Next slide. So the other thing as evaluators is, and this is where we start to geek out on you guys, is we love to get down into the numbers. So one of the first things to do is to get a descriptive data sets. This is looking at the race and ethnicity of the populations in the health centers. And I looked to see how reflective the folks were who participated, how reflective they were of the community at large that the community health center served. And as is true in terms of Idaho in general, we're not a very diverse state. Our dominant race and ethnicities are Caucasian and Latino Hispanic. So that was reflective in terms of the socio-demographics. I did similar charts for the household size. The participants within the study, most were from a 2-person household size, but the household sizes actually ranged from 1 person to 10 people. And as Ray and Lindsay said, that was used to determine how much to provide in terms of fresh produce. So the monetary value of the vouchers was used for that. I also looked to see in terms of food insecurity, were we reaching a food insecure population? And indeed, the majority of the participants in the program were food insecure. Next slide.
Have to separate.
Excuse me? So then I went to see were there significant associations. So let me talk a little bit about this word significant. When we do statistical analysis to see whether or not a program really made a difference, we look at whether or not it is statistically significant. This means that there's a 95% chance that taking that action, taking part in the program, led to the decrease in A1C. So if you kind of think about playing the lottery, if you have a 95% chance of winning Powerball, yeah, I'm out there buying a ticket. So we were looking at, for this program, at a couple of different factors. First, we just looked at A1C in general. So did participation in the program help participants to get better control of their diabetes? And indeed it did. We found that it was statistically significant. So that was super. And then we wondered, well, was it the vouchers alone? There are studies that show that for patients who increase fruits and vegetables, you will see a decrease in A1C. So, you know, what is it just a matter of giving patients produce vouchers to get their A1Cs in better control? And we actually found out that the vouchers alone were not a significant factor in reducing A1C or BMI. So it wasn't just provision of the voucher, those other program components, meeting with the RDNs and the behavioral health and pharmacists and taking part in the group classes and the cooking matter classes, they played a role in helping people to bring down those A1Cs. Next slide. And so then we looked at a whole bunch of other questions, and this report that I did, I think it was like 45 or 50 pages. So I could be up here forever, but I just tried to highlight some key things. So we did also look at the cooking classes because, as Lindsay said, they were very popular. And so we wanted to know, was participation in the Cooking Matters class, which actually gave an opportunity to have a group intervention with a dietitian as well, did that make a difference? And we did find that there was a statistically significant change in terms of A1C. So those Cooking Matter classes really were significant. We also found that behavioral health appointments plus voucher redemption led to significant reductions in BMI. So this was an unexpected finding, in part because of the length of the programs. It was relatively a short intervention, and often it's that length of intervention isn't long enough to see a significant change in BMI. We do know from the literature, however, that power of that behavioral health counselor in helping to promote behavioral change. And not everybody reduced the vouchers. You know, there was just a small percentage who redeemed them 100%. But we found that those who did redeem those vouchers and met with the behavioral health counselors did see a reduction in body weight. So that was a neat finding. We also wondered if we were really helping to make a difference for the folks who were food insecure. And as I said, the majority of the participants were, but we did have a small percent who responded to the food insecurity questions such that they were classified as food secure. So I was allowed to make a comparison and see whether or not for those who were food insecure, was program participation making a difference? And indeed, I did find that there was a significant difference in A1C, that folks who were food insecure were able to get better diabetes control by participating in the program. And that was true for both years for Terry Reilly and for the first cohort in Valley Family. I'm thinking that the COVID interruptus during year 2 for Valley Family is why we didn't see that same that same statistical significance for the second cohort in the Valley Family group. So in conclusion, this program was found to be effective. Statistically significant changes were seen in diabetes control. Right now, I am working on an article for publication. And for the article, I've further separated the participants into groups in terms of their level of diabetes control. So there are folks who were within normal limits, in control, out of control, uncontrolled diabetes, and critically high. And it's interesting to see that there was no one within normal limits, of course, because they wouldn't have been eligible. But at the end of the program, there were some participants who ended up within that normal limit category. And mostly what I'm finding is that folks who were critically high shifted into uncontrolled, and uncontrolled shifted into control. So those are really exciting and powerful findings as well. So that's what I thought I would share today to give you some highlights. And I'm going to pass it on now back to Ray and Lindsay to talk about their lessons learned.
Thanks, Barbara. That information is always a good, even just for me to hear and review. I was like, oh yeah, we really did make a difference. So just kind of reviewing it, I think we both, Ray and I, spoke to some of these already in our part of the presentation, but just kind of a few highlights is, deciding to allocate sufficient resources. So besides just money, right, to pay for the vouchers themselves, just know that managing an effective program really requires a lot of coordination and staff support. So utilizing the help of your care team, hopefully, is the best way to make this happen. So if you have community health workers or health educators, if you have behavioral health counselors and providers that can really help with all of the pieces, that can be helpful. The other is keeping cohorts small. And so for me, I guess what I would suggest is that really targeting the most vulnerable. So those that have the food insecurity, those that have, the higher A1Cs, that really require some more kind of individualized, help. That if you were going to keep your cohort small, that's who I'd focus your efforts on. And that just really, especially if you are a small clinic or don't have the staff capacity to provide, the vouchers and the program to hundreds of people like Ray did. But those would be my suggestions. The other piece is really including that socialization, so social aspects, even if it's not Cooking Matters. I don't know, Cooking Matters is definitely one of those evidence-based programs that I really think is important. And I will say this, that Cooking Matters is not necessarily intended for a dietitian to always instruct, but that's one thing that was a little bit unique for both our programs, is that we could tailor some of the education for the participants. So because we knew that all of our participants had diabetes, I tailored some of that education specifically around, when we would read a food label, we would look at the carbohydrate content. We would talk about how you could reduce the total carbs if you were, needing to reduce those even further. And they're intended sometimes to be taught by volunteers that may not necessarily have that expertise. So that's something to consider. And then the other is making sure that, especially if you're wanting to, make this sustainable and show that it's a valid program and why we should continue it, is using those validated and educational both the evaluation tools, I guess, and education, both. And then between our clinics, really looking at, are we comparing the same things, collecting and comparing parallel metrics? So we're evaluating the same thing was really important. And then some of the outcomes that came as a result, we did speak a little bit to that. The ones that I have benefited from was the continuing funds from our coordinated care organization in Oregon to continue programs like this. I am working on and Share Our Strength is actually providing some best practices for providing virtual cooking matters, and I've been kind of piloting some of that. And then I'm going to let Ray speak to her position and then our dietitian peer group too.
And I'll just chat for like 1 more minute on a couple of kind of final thoughts on our end at Terry Reilly. And then in the chat, Sarah and Lindsay, I'll kind of let you decide. We may want to consider doing questions for the last 5 minutes and kind of skip out on the mentee, but I'll let you guys kind of decide while I talk about the other couple that I have. So my, I guess, couple, 2 or 3 big take homes, my biggest one being, I did not spend enough time really establishing a solid team to help me run this kind of straight out the gates. I got hired and we kind of just hit the ground running and gathered more people kind of along the way, especially in year 2, but really drawing out that process map, who's in charge of what, who can do the evaluation for you, because there's never time to do the work and the evaluating, I can tell you that much. There's plenty of colleges in all of the schools, and that's been great to have ISU alongside us. So that would be my biggest one, is making sure you have the resources such as the people more than anything, and really taking the time to plan it out before you jump in with both feet. I wish I would have at least. And then my other kind of lesson learned, I guess, is just to really consider the grocer. Our small grocery stores were incredible. So not so much within this program, but there have been other grants that we've applied for since, and all states and regions have multiple grocery stores usually, and there's some that our patients shop at and there's some that our patients don't. And we've had a couple grants come through that partner with the big grocery stores that have enough funds for some philanthropy, and that's amazing. But sometimes they're a little bit too expensive for the population we serve. So really taking into consideration where your patients shop and where would be best to send them would be my, I guess, other take home. And then again, I feel like it might be important. We only have a few minutes left just to open it up for questions, but what do you guys think, team?
Yeah, I think that's fine. I can share the doodle just because the word doodle, because I can see that people are already putting their information in there, and we'll just do this one question, and we can just throw out questions or open it up for questions while that word doodle is up so that you guys could see it, especially since I practiced so hard on doing this right.
Yeah, share it to the screen, Sarah, and then we can kind of answer questions at the same time.
Yeah. So these are some of the words that you all have provided in response to the question of what barriers impact your patients from having diets rich in fruit and veggies, vegetables. And the bigger the word is means more people said the same thing. So I'll let you guys kind of take it from there or open it up for questions if anybody would like to ask the program anything.
And I'm not sure if one of our moderators is kind of helping. I see one question up in the chat. There might be multiple higher up. And then I don't know in terms of people on the video, but let's field some questions.
We do have several questions that have come in via chat. We probably won't have a chance to get to all of them, unfortunately. But I will go ahead and start. If one of the questions that came in is if you were able to track outcomes for the children of families participating, and if you have any strategies for improving outcomes for youth or juveniles with diabetes who are at risk.
I would say that there are probably opportunities depending on where you live for similar grants, or at least involving food and food security to really focus on kids. One of the ones that we have right now at Terry Reilly is providing gift cards to go get healthier foods, and it's focusing on families with children in the home. we have a large population that we're trying to serve. So it's hard to get these families that have 5 or 6 kids, all those kids' weight and health data. But with a small enough population, you can track whatever you would like. So long as the families are willing to really take part and provide you that information would be my answer.
Yeah, it's true. We did not collect that information for the whole household, just the patient that was initially referred with the high A1C for our program.
The one that just popped up in the chat, the recipes and are they reasonably priced? Share Our Strengths is a national organization that puts out the Cooking Matters curriculums, and every recipe in that book is affordable. It includes a whole grain, fruit or vegetable, I think both or either, and the participants get to take the whole book home with them. So all of the lessons and all of the recipes that are included in the back. So it's a really sweet program.
Yeah, it's like $1 or less per serving. Yeah.
Thank you. I'll do one last question here. And I'm also just a reminder that I'll post the evaluation link in the chat as well. Please take a moment, folks, to fill that out. That helps us greatly. So another question that came in is, what can you recommend community health workers do to help patients be consistent in showing up to virtual appointments and to be open to services that health centers provide given the COVID restrictions?
Do you want me to speak to that, Ray? We did have, we had our community health workers call our participants prior to each class just to remind them. We have had to utilize them to help with providing instructions for individuals to access Zoom, to do virtual appointments, virtual classes. But that's definitely been a big barrier. Even if they have, many of them don't have internet access from home. So even just, or a smartphone where they have the capability. So especially a lot of our Spanish speaking families would have to rely on help from their relatives or family member or younger, person in their household to utilize their equipment or help them to get logged on with the virtual appointments. For sure. So we did phone calls, if we had to for some of them. We really just we just did what we needed to do to make sure that contact was made.
Thank you for that.
Mm-hmm.
Well, thank you all again for a great presentation and a great project that you're doing there in Idaho. Really appreciate the information. Thanks to the participants for joining for our session as well. And we hope you have a great rest of the day, and please join us for other sessions throughout the conference. And also we'll encourage everyone to please join us tomorrow for our closing plenary. We'll have Roberto Danzi speaking, who is a longtime friend and colleague of the migrant health and community health movement, and he's very inspirational, very motivational. We hope you'll join for that. So thank you again to our speakers, and thanks to you all for joining us. Have a great day, everyone.